us down this path. Historical tales come alive, where science and stories dive, blending facts with heart, knowledge from the start. Need bridge blues we sing to the future memory. Health and science in the mix. Maybrick's got the fix. Complex subjects made
right
clear.
now
Every episode
in ways that we actually acquire the
leads the way,
and ways that make me more efficient.
in the world of digital streams, turning knowledge into dreams. Through the tales of old, new stories unfold.
Thank you so much for joining with me. It is truly an honor and a privilege.
MedBix Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges on our live programming.
Hey, welcome to the MedBix Webcast. This is Raman Annamaraju. I'm the host. So we have a very interesting program today. I'm going to talk with a doctor from Nashville, my favorite town, because my son went to school there, Vanderbilt University. He did neuroscience there. So I used to frequently visit. I stayed there 3 months or so, short time, but I'm always loved Nashville. People don't know from outside of Nashville, Nashville is the epicenter of healthcare. It's a huge healthcare technology-wise, the management side of wise. It's a huge, is a very big in healthcare systems there in Nashville. There's a Hospital Corporation of America, headquarters for a Hospital Corporation of America. It's CA, founded by Dr. Bill Frist and his family. So Dr. Bill Frist is a cardiac surgeon. He's very well known in Nashville. But I have a doctor. Today we're going to talk about hospital medicine a little bit. That's a very different kind of new field emerging recently. Recent means last decade or so. The doctors are employed by the hospital itself, and they're providing the hospital care and the hospital admissions. Otherwise, I used to remember doctors used to go into the home hospital on calls. They have to get up in the middle of the night, leave their wife and children, and go there. And they used to hate it. Now that is kind of things is a new kind of system evolved, and then the hospitals are hiring these new doctors, young and they work in odd hours. They need a lot of young people. That is the hospital doctors. We'll ask the upcoming doctor. We're going to ask him about that. Then he is also pioneer in the value-based care. I was a witness. I was not a part of that value-based care, but I was a witness to the value-based care, how it evolved so far. And technology and also AI we're going to talk about. I'm going to talk about a little bit about magnetism in healthcare, a little bit that I'm going to present a topic. Let me introduce you Dr. Dennis Deruelle. Deruelle is joining from Nashville, Tennessee. He is a old-time physician, but he has a update technology. He is always in the forefront. He is updating his knowledge. So, that is I admire people. There is no excuse. The age is not an excuse. You have to really update your knowledge. Actually, you can provide, with all the wisdom that you have, with the updating knowledge, with the technology that you have and everything, you can provide a better guidance to the younger people, and the really you can design healthcare systems better. Dr. Dennis Deruelle is an author of the Healthcare Playbook, and he is a doctor. He's a primary care doctor there, and he is an advisor, fractional chief medical officer, and he's an innovator. Everything is there. Let me bring him to the table. Dr. Deruelle, welcome to the MedBix Webcast, sir.
Thank you, Ramana. It's really a pleasure to be here with you tonight from Nashville.
Thank you. So let me ask you, just to talk about a little bit about Nashville background, and then and talk about your background a little bit. So if you don't mind.
Absolutely. I think you hit the nail on the head. Nashville is a hub where it's a nexus for three really big things coming together, from my standpoint. So healthcare innovation, in terms of value-based models and investments. Number two, it's, as you mentioned, it is a technology center, and it is a headquarters for many large hospital corporations. And so you have new models, either of healthcare or investment. You have technology, and you have healthcare systems, large hospital systems, some of the best in the world. So you put that together, and we have a crucible here that's heating up quite well. Secondly, as you know, Oracle is moving here. Oracle owns Cerner, of course. And so the more people come, and that's how you get a dynamic center of excellence like Nashville.
So just tell me some of your background, that if you don't mind, your background a little bit, that would be good.
Sure. Well, I started out as a primary care doctor, the kind you mentioned a minute ago that used to be on call. I had to go to the hospital and be there all night on call for my group. And that was back in the 90s. At that time also, I started a technology company in 99 that was literally a tablet at the point of care. It was called a Slate. It was so heavy, it weighed about 12 pounds. We also had fingerprint recognition by a company in Melbourne, Florida called Identitech. And of course, we were using Dragon. And so I started that company, Firsthand Information Systems, in 1999, if you can imagine that. But I like to say we had a car radio, but nobody had cars yet. We really needed electronic medical records to take off for that company to do well. But it did have some success, absolutely. Then I transitioned into the world of hospital medicine in early 2000s. And instead of doing all these jobs, going to a nursing home and a skilled nursing facility, being a primary care doctor and seeing patients in the hospital, I basically did a third of that job. As you mentioned, that's how hospitalists really developed. So I did that. I sold my practice to a company, IPC, out of North Hollywood. I rose to become their director of innovation nationally. And I also was the acute director of the hospital medicine programs across the United States. Then I went to a company, Team Health, because they were bought by Team Health. And I went into value-based care. I was really the main principal physician running bundle payment program, which is a massive value-based care program. Then I got recruited away to do to run the U.S. for hospital medicine and critical care for American Physician Partners here in Nashville. That's why I moved to Nashville. Since that time, Ramana, I've been still seeing patients. I go up to Boston. I teach at a teaching hospital of Tufts, and I'm still in the trenches as an actual hospitalist. I have my consulting company that I've had since 2009. And then finally, I'm doing some fractional CMO things for 2 startups. So that's kind of a snapshot, Ramana. I hope that helps.
Very good. You have impressive credentials you have. Let me ask you a little bit about the hospital medicine. I used to place a lot of J1 doctors and placements as physicians across the country. A lot of hospitalists they became a hospitalist. So these are young people. They don't have kids, or they have, they have a lot of energy and all those things. Is that they work on odd hours? Is it a challenge for the hospitals to recruit these hospitalists because their hours are a little odd? Is challenging, or what are the positive things and negative things about this hospitalist program? Tell us a little bit about that.
Sure. Well, hospital medicine came about. The word was coined by Dr. Bob Wachter and Neil Goldberg in 1997. Dr. Wachter, I did a fellowship with him through our company, IPC, in San Francisco. Of course, he's at UC San Francisco. He's really considered the father of hospital medicine,
Yes.
among a few other physicians, obviously. But the reason it came about was the hospital, as you know, gets one payment, right? They get a DRG, one payment. And it doesn't matter whether the patient stays 1 day or 50, right?
Yeah.
And so they needed efficiency. Then they started to be judged on quality. And it wasn't good enough to have the primary care doctor drop in and out every now and again. And they needed an expert who focused only on the hospital, and all they did was stay in the hospital. So that's the model. However, the model is more complicated than you think. You can be hired by the hospital. That's about 60%. You can work for a company like I mentioned, a national company, a multi-state company. You now can work for a primary care group, a massive primary care group. They have their own hospitalist. All they do is go take care of their patients. And of course, insurance companies, you're in California, Kaiser, many of the insurance companies have gotten their own hospitalists. So there are many kinds of models, but at the end of the day, we are experts in the systems of moving patients through healthcare safely and efficiently. That's really the key. Now, the demand has always been high. It was very high during COVID, of course, because some burnout came about from that. But I would still say, other than certain cities like San Francisco, where many people want to be hospitalists, I'd say it's still, we have a shortage, and it's still really a good market for doctors that want to get into this field.
You mentioned COVID-19. Just let us talk about what are the lessons you learned during the COVID in rural Tennessee or San Francisco. Tell us a little bit about that, your experience during the COVID-19.
Sure. Well, I was a consultant. I've been a consultant for a company called Cepheid for many years. I had just spoken at their international conference in Nashville in January of 2020, if you can think back. And then I got a call on February 10th or 11th by their company, and they said, Dr. Deruelle, we're calling all our consultants and asking them some questions.
Yeah.
And they said to me, should we develop a test for the novel coronavirus? And I said, the CDC's test is not working, so yes, you should. And of course, they went on to develop that. So I was involved in thinking about the novel coronavirus in January and in February of 2020. But the lessons that I learned about the middle of March, all of my doctors across the US were looking to me to tell them how to treat COVID, right? And so one thing I learned, just like I had learned from HIV, that is, you don't wait for all the answers. You're going to have to learn on the fly. I watched videos at night from intensivists out of New York City that were coming home. They were getting on YouTube. They were talking about what was working. And I took a system that we use for billing, and I asked our doctors to answer 5 questions. Are they on hydroxychloroquine? Are they on remdesivir? Are we proning them? Are they on high flow oxygen? And are we putting them on steroids or an anticoagulant? And by looking at that data early from our thousands of patients across the US, I was able to get some early signals. And so what I was doing was putting patients on remdesivir, and I was telling our doctors to put them on that drug and to put them on steroids as early as March of 2020. And what that ended up doing, Ramana, was our mortality rate was much, much lower than other places around the country. And so one lesson I learned is do not wait. You've got to move, make your best guess, and share information. I think that was really an important lesson.
Now you went on to the value-based care. Let us talk about bundle payments. I remember those days that doctors used to hate that. Probably if you mentioned the bundle payments, they used to hate you probably. There's a lot.
Oh yeah, they didn't like that. No,
they didn't like that at all. And then bundle payments, then DRG, bundle payments. What are these effects of the value-based care brought that to the hospital system. Then let us talk about the hospital itself, the value-based care. What are the challenges as right now they are facing now with the value-based care? It went through evolution of value-based care, right? When you wrote a book called Healthcare Playbook. I don't think even the healthcare experts can understand the healthcare systems nowadays, how to navigate. So tell us a little bit about this,
Yeah.
the value bundled payments and value-based care, how they started it, how you participated in it.
I'm really glad that you brought up my book because I wrote my book with the help of the NFL. And the idea was the NFL is so popular
Yeah.
that I want to use analogies to explain complex things. Healthcare already talks and uses Toyota. They use aviation as a model. I wanted to use the NFL only because it's ubiquitous and understandable. Anyway, when I was preparing to write that book, Ramana, I had to read the Affordable Care Act. And if you recall, it was 2,000 pages.
Yeah.
And when I read that in preparation for my book, I was astounded at the value-based care programs the Affordable Care Act was creating. ACOs, right? I was sitting there reading that hospitals were going to be reporting on value. Value is quality over cost. Quality over cost, right? Maximizing that equation. And I couldn't believe as I read the Affordable Care Act that all of this, and I had, Dr. Wachter at UCSF, when he talked about this, I really knew that was going to be the future. I knew it was going to be. And so as you look at value-based care, it's grown obviously since, 2009. But there are some, and the whole idea is that you're going to improve quality and reduce cost and do it all at the same time and make sure the patient outcomes are good. The problem is it's hard to do, number one. And number two, in these value-based programs, Ramana, the government is sharing some of the savings with the providers. And if you look at the net on that in the end, a lot of people are arguing that Medicare isn't really saving money. So if you want to get into some of the problems with these models are that we need to make sure that we save money in the end and there is real quality improvement.
A lot of political organizations in politics wise in the South, particularly where you are at and where I lived in Georgia. So they did not like the Affordable Care Act and they resisted a little bit. One of the challenges of the Affordable Care Act is he did not address everything. One of them is a legal, the legal system that did not, the malpractice insurance side of it. So that was not addressed. Second thing is liability issue itself. If you don't do anything, this your one side of it is that don't do anything so you can save the money, but that also create a liability itself. If you don't do anything, some people die. So
Yes.
how do that balance? How do you checks and balances that Affordable Care Act missing?
Yes.
The value-based care. That's one of the process. One of the complaints about the value-based care, particularly Affordable Care Act, right?
Right. Well, I look at the Affordable Care Act like this. If someone asked you if you like the IRS tax code, what would you say? There would be things about it that you do like, Ramana. There are things that are good in that tax code and probably things you don't like. And it is such a long code that who could ever say they love everything? The Affordable Care Act was so long and big and profound that there were things I liked about it. There were things I didn't like about it. You've brought up one that I did not like. The only thing they did with tort reform was have a few pilots done by the states, which were nothing. Yeah. I would say the biggest flaw in the Affordable Care Act is this. They should have given everybody credits and put them in the exchanges. You know that the lowest, under 128% of poverty, were supposed to go on Medicaid, but all the states did not expand Medicaid. So they left a gap of millions of patients. Now, you can blame that on the Republican states or whoever didn't expand, but at the end of the day, I think that was a flaw in the model. They should have put everyone in the exchanges, regardless of their income, all the way down to zero, and we wouldn't have had this problem.
Yeah. Let us talk about the hospital a little bit, about the value-based care in that sense.
Sure.
A hospital two-side coin. That is two-side coin is what hospitals are. Sometimes they're expensive. The care is extremely expensive. You're going. Another thing is this in the fee for service model. At least what the complaint doctors were complaining about, that is that you're creating a casino and tell them not to play. That's one of the complaints. But that hospitals are, how do they reduce the cost? That's one area, one argument. The other side of the argument is rural side. That's the only hospitals can. That's the only thing people have is the rural hospitals that can save lives. So how do you balance this out, Dr. Deruelle?
Yes, well, hospital care is very expensive. And the idea behind value based care, honestly, is more about the population of health. So you're looking at a population, and the hospitals are a great center to achieve that. But you don't have to be a hospital, of course. You could be a private company and be in an ACO and be in value based care. But I think the conundrum for a hospital is just like the analogy that I use in the NFL. When the NFL first started putting games on TV, they were worried that people wouldn't buy tickets to their games anymore, right? But it turned out that they were going to watch it and go to the games. Yeah. But in value-based care, think about this. You're supposed to take a lot of people and avoid them from coming to the hospital. And yet, if you do that extremely well, you'll reduce the patients that come. So that's antithetical to your business model if you want people to come through the hospital. So one thing about value-based care is hospitals have to realize it may reduce some of their volume, but they're going to need to get paid in a different way based on their performance and sharing the savings. So that's number one. And number two, rural hospitals, they're suffering greatly right now. And I have to say, with this new bill that got passed and the way Medicaid is going to be handled with taxes and how it's going to be requiring other things, I think rural hospitals are going to suffer, and they need ways to increase their margin because they won't stay open.
Let me pose a question to solve that problem. Is it possible? It's just a thought I'm just running through you. Is that, can you do the hospital episodic care? They do episodic care, right? So yes. Can you make it as a episodic care, federally subsidized, and then move the rest of the care, chronic care, disease management, all the that is the biggest chunk of the problem, right? Move to the free enterprise system. All the doctors and all the service providers can provide that kind of things. It's going to be cheaper that way. What do you think of that solution for the rural hospitals? Subsidize them and then provide rest of the service providers, give them a free enterprise system. There's a free market system to do that, providing services.
I think that's a great idea. You could do it in so many different ways. We could call it a subsidy, however you want to do it. You could call it a safety net. You could have a federal system where if your hospital fits into a certain rural area and you meet criteria, then, we already do have some things that we do for small and critical access hospitals. It's not as much a subsidy. It's kind of a break on things that cost them a lot of money. But I think that's a great idea. At the end of the day, I'll say this. We need a baseline safety net system in the US. And I believe now, I used to never believe this, we probably need something universal. I believe that. And then have another tier of private insurance if people want it. If you look at other countries like Australia, if you look at, European countries, even when they have a universal system, they now have a private insurance layered upon it in some way. I ultimately think we probably need to move to a model like that.
Very good. Thank you. But, I think that is let us talk about the technology playing a role. I think, a lot of remote patient monitoring, all these devices are coming in. You can do a lot more. You can take the care to the patient's home. So yes. You can reduce a lot of admissions, and then you can manage from remotely their care, and then warnings of the warning signs, and then you can always collect all the information. I'm in Silicon Valley. There's a lot of AI based technologies coming up. It can predict even in advance. Somebody said that there is a one you put in the wall. It can recognize the heartbeats with the acoustic side and then see that if there's something going on.
Yes.
So why I think need to embrace this technology and then move this chronic care patient management to the primary care to the patient's home and deliver most of the care to the patient's homes. Why we don't have a national strategy in this direction, Dr. Deruelle?
Oh, I wish we did. Are you kidding me? There is no national strategy in that. They're looking for private companies to innovate, which I'm all for. But let me say this. I'm now a CMO, a fractional CMO for a company, Vitas Sora. Vitas Sora, it's a company that does remote patient monitoring. It does chronic care management. They have a device that can detect patients' lungs wheezing, and they're using AI in virtual clinics to do everything you said. And our specialty is partnering with value-based care companies. We just signed a deal with a company, TPAC, that has 15,000 Medicare lives, and they're expanding. And you set up a value-based model on exactly the things you said: better outcomes, keep patients at home, keep them out of the hospital, find unique ways to monitor them, allow AI to show us the algorithms to help us know what's important and what's noise, right? That's where AI really helps. And at the end of the day, that's going to be the future. What I would say to you, though, is that we need certain things that we don't have today to train AI. I'll give you an example: photographs, audio of patients' voices, and video of patients. We need data sets to train AI on those kind of things, and they don't exist today. They're here and there. And so I look for remote patient monitoring companies to develop ways of looking at video of patients and detecting things and being able to train AI.
Yeah. I think that is still a long way to go. Still a learning. There's a very technology-wise a lot of complications there. I think
Yes.
is a evolving field. It's an artificial generative AI. It has to be so video and audio and all the natural language that even the talks itself that mix them together and like by recognizing voice or Parkinson disease, all these things you can recognize through that. I think it's going to take some time, but we are in the right direction. But
But Ramana, can I ask you a question? Because
yes,
I want to pick your brain. Um, Another company I'm involved in is Neurosensa, and we have a device that measures the electronic conductance, the electrical signal on your skin, and it can measure pain. We now have something that will measure pain. That's something that's never really existed.
yeah,
Now we have to use AI to do that. We have to do that with AI because we need to separate just someone sweating or someone being anxious from having real pain. And we need millions of data points to let AI help us be accurate with that. But my question to you is this: how is it that healthcare is going to be able to sustain a massive growing database with AI when they're not, Anthropic, and they're not, Mark Zuckerberg and Meta? And how they can afford to lose millions of dollars every day. But these startups, how are they going to get cheaper AI down the road when they're not one of those massive companies? I'm interested in your idea on that.
I tell you that is a very good question. It is a frustrating. It is a national. You and me cannot solve that problem. Has to be at the president level, at the national center. We have to come back with a decentralized this intelligence. You
Yes,
cannot you cannot keep the intelligence is centralized. It doesn't work. It is
yes.
a failure in that sense. It is always controlled by some few people. That's what is happening in Silicon Valley. These a few companies are controlling the entire world. It is really is one of the challenges we have to really address that. At the
Mhm.
policy level, it has to be addressed at the policy level. I agree with you. To be honest with you, I don't have the answer. There's just I'm always talking about that, raising the questions about that, where these distributed intelligence has to be there. How
Yes.
did you do that? distributed intelligence to these people.
I
That
agree.
that is the people has to question, because these are all taking advantage of a little bit. These companies, they don't have a governance, whole lot of governance, and I think we need to implement some governance on these IT companies, technology companies, and then we need to move on to the. I agree with you so far. Let me ask you, that's one reason doctors are skeptical about the technology, right? Because the
Yeah.
electronic medical records did not give productivity, did not increase the efficiency is improved, the productivity or efficiency, one of them is always losing there.
Yes.
So electronic medical records is added so much pressure on the doctors, it did not achieve the results what they claimed, these IT technology companies. So how do you think that with this technology skeptical doctors, how do you convince them using embrace technology nowadays?
Yes. Well, I would say this: AI right now is being used with ambient listening, and it's creating notes for doctors. That's certainly a win. It's making doctors more efficient. Okay. That's number one. Secondly, AI is being used to summarize the patient. If they've been in the hospital 30 days, it's summarizing everything. We used to have to go back and read every page of that and tell our next doctor. So it's doing little summaries and it's making our notes for us. I think those are the two big areas that it's being used today. I would say, though, if we are not ready to use it for medical decision making, in my opinion, because we haven't addressed the medical legal side of it. And also, in order for AI, and not just in healthcare, AI in many areas, music, I'm here in Nashville, you're going to need to prove and timestamp when you used AI and when you didn't. You're going to have to be able to prove that.
Yeah.
So, like, if I'm in court and they ask me, Dr. Deruelle, did you use AI? I need to be able to have that proven, and it needs to be shown and timestamped and followed through a chain. And sometimes I believe in the future, you'll be sued for using it and you'll be sued for not using it at a period of time. So I would say we need more rules, Ramana, and we need more regulation and guidance on that before AI is going to go any further than we said in electronic records.
Yeah, absolutely. There's some faction of people, some faction of in this country, they don't believe in the regulations. What they do, they think that we need to, but I seen these fake videos is so real. They're
Yeah.
real. The human beings are not even there. They're acting like they're telling something. If you don't stamp them, they are AI. People are going to deceive you. Somebody come back with the fake medicines and then say you this will cure cancer, ignore everything else. That kind of a fake video can really destroy the can kill people. That is a absolutely valid question. We need the regulations. I think there is a cohesive the we need to have a national policy on that one, the regulatory policy on the AI. I agree with you on that one. But I
Ramana,
wanted to talk
I
with
ask you,
you.
I want
Yeah.
to make another comment though that I think is really important. When when I'm teaching residents,
Yes.
I do not want them. I use something called open evidence, which is AI. I ask it questions all day. I use it in the hospital. It does help me. I can't know everything in the world. And so I will ask open evidence, and it's using certain journals. It's using AI to find it for me. But what I don't want is my residents to rely too heavily on that and not learn how to do those formulas to calculate everything in the old school way, so that, the whole idea that if the autopilot ever went out, you could fly the plane, right? I don't want our doctors that are learning to ever be too reliant on AI. They've got to learn it the right way first.
Yeah, we've seen it, the Boeing 737, all these new technologies went down, because of so we need to, that is where really they are going to end their paycheck at the crisis time. And I agree with you. Dr. Dennis Giral, and, he's a really innovator, educator. He is a really fascinating background he has. Now he's one of those doctors that they have such a wide variety of breadth of knowledge that we need to use. The nation is a treasure for the nation. That kind of people, that not only for the United States, but for the world, in my view. So I'm going to talk about a little bit about it, and then come back and we'll ask Dr. Deruelle about his contacts and what is technology, how he's going to implement. You think that how do you solve this healthcare crisis, these uncontrolled costs, and we will ask him about that a little bit. So I'm going to talk about, I'm a physicist, so I'm going to talk about physics of the healthcare a little bit. Today I'm going to talk about a magnet. This is a magnetism and electricity. I'm going to talk about it. Everybody knows that. Dr. Deruelle, you can jump in anytime you want to. We were talking about NCB actually. ECG, electrocardiograph, is the our body is go through a lot of electrical system. We measure the heart produces, the heart runs by electrical system. That's why we measure the electricity. That's why QRS complex comes there. You can measure the even ST deviation, all those things. You can measure the electrical signals from the heart. We can tell how far, when did they have a cardiac arrest or some other problems, they have heart attacks. All of them you can say that through electrocardiogram. That is electrical, measuring the electricity. NCB is a nerve conduction velocity that Dr. Deruelle is talking about it. By skin, you can measure the velocity of the current going through the nervous system. Carpal tunnel syndrome, I'm in Silicon Valley, a lot of people complain about that carpal tunnel syndrome. All those things you can measure through NCV.
Yeah,
So all of these things, the NCV, nerve conduction velocity, electromyograph, these are the measure the electricity. Another one is EEG, electroencephalograph, is a measure. Our brain is a 10 watts bulb, so you can measure the electrical signals from there and see any pathologies in the brain. But I'm going to tell you, wherever there is electricity, there is a magnetism. Remember, they're inseparable. Like husband and wife, long-term married, they are inseparable. When there is electricity, there is a magnetism. So why we are not measuring the magnetism? Magnetic systems, magnetism measurement can give a higher resolution. Spatial and temporal resolutions must be much higher. The reason is our Earth's magnet is so powerful, so it's very challenging. But we found a way to solve this problem. I'm going to bring a small. So our body produces the electricity and the magnetism. Brain aura, they call, some new age people call aura, but it's actually the brain produces the magnetic waves. The body produces the magnetism. Heart produces quite a bit of magnetism. So we can, because these are electrical systems, you can measure the magnetism on those systems. What is the advantage of that? I'm going to show you a quick video. I'm going to play with you. If you don't mind, let me just add that video, add a scene. Yeah, I'm going to add a media, just a quick video. I'm going to show you. This is
You might have heard about a psychic squid that predicts a World Cup winner, or at least you have seen at the dinner table. The squid I am talking about is neither. This squid accidentally fell on us 100 years ahead of its time. The squid contribution to the medical field is invaluable. It revolutionizes the way you predict and diagnose diseases. This squid hunts cancer cells like you've never seen before. It will pick up source of seizures in the brain like no other. It is just not picking the needle from a haystack. It can pick your lost nail from the Appalachian Mountains. Hello, my name is Ramana Anamaraju. I have a passion for physics, specialized in allied healthcare, and above all, concerned for well-being of all humanity. Edward Flynn was hit by tragedy twice and lost both of his wives to breast cancer. When his first wife fell in coma, he used to visit her at the hospital. He used to whisper in her ears, wondering she may be understanding what he was saying. After a few months, she died. Not knowing his wife understood his undying love for her or not is frustrating. Then second wife, after a brief marriage, lost to breast cancer again. He is determined to do something about it. Edward Flynn is neither king nor can afford to build a Taj Mahal in memory of his beloved wives. But he built something better. He built SQUID. Acronym for SQUID is Superconducting Quantum Interference Device. As strange as that name is, this device is out of this world. He brought a mystical and elusive quantum nature of our universe to the benefit of the world of humanity. Edward Flynn is a nuclear physicist at the prestigious Los Alamos Defense Laboratories. He gave a remarkable gift from mother of all sciences, physics, to the field of medicine. A new machine, magnetoencephalograph, was born, usually referred as a MEG scanner. This exotic hair-blower looking machine is a mag helmet made up of several squids, which are quantum devices that are designed by Edward Flynn's team. This machine, without touching the body, can read magnetic fields coming from a body that are 100 million times weaker than our Earth's magnetic field. Amanda Malmsberg of Wisconsin fell on the kitchen at the age of 8 with a first epileptic seizure. She was getting seizures almost 100 times a day by the age 16. With the help of neuroradiologist Dr. Deepak Raghavan, they made a journey deep into her brain by using MEG scanner.
MEG, or magnetoencephalography, is a relatively new tool that's become available to us, which is capable of looking at the magnetic fields generated by the brain and localizing them back on the anatomy of the brain. At this time, Fredericton Medical College of Wisconsin is the only center in Wisconsin which has a clinical MEG program. We do see patients from not only our hospital but other centers as well. Most people are familiar with electroencephalography, or what we call EEG, where you record brain activity or brain waves from electrodes that are planted on the scalp. Now, there is a substantial amount of tissue and fluid that separates the generators of that electrical activity in the brain and the locations at which we are recording this electrical activity, including tissue such as the skull and scalp. So that can substantially alter the view of what we are looking at in the brain, pretty much in the same way that if you're trying to listen to a conversation through a thick wall, you hear muffled sounds. You may vaguely be able to place people in different parts of the room, but not quite clearly see who spoke from where. So alternative techniques which are not affected by the tissue is of great interest.
Without single incision looking for the elusive source of epilepsy, it is just like looking for a needle in the Grand Canyon. It is that difficult. They found the source of her problem hiding deep inside of her brain. No other modality, including powerful MRI, even come close to these findings. The very tiny source of area that is causing her seizures was surgically removed, and Amanda is living happily ever after without even a single incident of seizure. The woman's life was given back by this remarkable machine. The researchers racing towards to find that very tiny number of cells that causing Alzheimer's, schizophrenia, depression, autism, and chronic alcoholism, and many other brain-related diseases. MEG scanner is taking on the most challenging and the deadliest disease of all for women, breast cancer. With the present technologies, you need 10 million cells to be affected before it shows up on any modality or device like a mammography or MRI. But the MEG scanner hunts for those few thousand cells causing cancer out of 90 trillion cells, not a billion, 90 trillion cells. Probably MEG scanner can detect breast cancer 5 to 10 years in advance before any modality. Vanderbilt Gastrointestinal SQUID Technology GIST Laboratory is an interdisciplinary initiative by the Department of Surgery and by the Department of Physics to detect how to find stomach ailments. Can go on. This is a direct demonstration of quantum physics in action through a medical device while saving countless lives. Nuclear physicist Edward Flynn may not have saved his wife's life, but saved countless lives on her memory and will be saving millions in the future. It is better than a Taj Mahal indeed. Thank you for listening.
So let me take that one out. Yeah. This is, yeah. Let me remove that. And then I'm going to talk a little bit, one more thing. I just, I need to bring you that back. Just a minute. We had a scene. Okay. Just a media. Yeah. I thought I did. Okay. Just the last slide I have. Okay. I think, so what, these are the magnetoencephalograph. Now there it is kind of a new thing is coming up. It is called wearable and optically. I did that video 7 years ago. Now there is a lot of advances went on. There's a wearable and optical pumped magnetometer. This is like a, what they do is a rubidium gas they put on these, is in that hat, they're trapped in the rubidium gas, and they create a quantum state by throwing the lasers. What happens is a nuclear spin, the spin of electrons that actually become a quantum. Any magnetic field coming from the brain, any anomaly, any pathology, he can, by cell by cell, he can detect that place with this new helmet. So it is a very wearable. Used to be very thick. The previous ones are the magnetoencephalograph is heavy and cryogenics. You need to have a temperature way, even almost as close as in the space, the lowest temperature on the space. So this is, you can do in the room temperature. This helmet.
Mm, mm.
So advanced analytics is coming in, very Fourier transformations, or Ramanujan mathematics. Ramanujan, the mathematician Ramanujan sums is called. It picks up the weak signals and it gives it, amplifies it. So there is a lot of going on. There is a much more advances are going to come in this area. Is a diamond sensors. The In the Siberian crater in Siberia, there was a meteor fell in and created a huge diamond field. People don't know this. Is in Siberian crater is a trillion diamonds. Almost you can put a diamond on every girl or probably on the planet. So this created a huge diamond structure, but they're not the real diamonds for the weddings, but they're industrial and medical. It is impurity there in the diamonds. That impurity is called nitrogen vacancy sensor. Those diamonds are so sensitive. It's a quantum state. You can put on the skin, you can put on head, anywhere. It can detect very small pathologies, minute pathologies in the cellular level. It can detect. So we are heading for the greatest technologies in the future. Welcome. Thank you for joining. Let me bring Dr. Deruelle to the. What do you think, Doctor?
Wow, that's amazing stuff, Ramana. I think I'm working with, as I mentioned, a company, Neurosensa, and we measure electrical activity, not nerve conduction per se, which is a velocity.
Yeah.
We're measuring an amplitude of electrical signal of the nerve fibers. And as I mentioned, we're able for the first time to really show when someone's got pain and measure pain.
Yeah.
And so I agree with everything you're saying, whether it's what we're doing, what you mentioned, magnets are being used, as you know, in nanoparticles for contrast, for
Yeah,
MRI.
correct.
It's being used for sphincters, like of your esophagus and for your rectum.
Yeah.
And so I think all the technology that you showed is on the forefront, and obviously quantum physics
Yeah.
and quantum computers and quantum physics is really the future.
Yes, I agree.
Absolutely. I think
Thank,
that stuff was amazing. I'm really excited to see more of that.
thank you, sir. Just to that, I want to bring the innovation. The reason I bring this, like you, that you're very open-minded and they're listening to other things. If the physicians, I'm in Silicon Valley. In Silicon Valley, it's hard for them to learn medicine. It's much easier for you to learn technology, at least on the grasp, and then physics and mathematics, than these people learning medicine. Medicine is very complex. I can tell you from my point of view. My father is a doctor. I didn't learn anything. So I think you're all equipped to do. You can do a lot more things with the emerging technologies, because you can just. That's the reason I started this channel, because to empower the doctors to learn a little bit more about a little bit of mathematics, a little bit of physics, a little bit of art and psychology. All of them are very important, in the innovations field.
Well,
That is
I
a
think I'm intrigued to look at magnetism as we look at consciousness. So, as you know, consciousness is kind of like time in physics. If you ask someone what time is, it's hard to actually to explain it. We can put it in a physics formula, but if you say what is time, what's it, other than a unit of time and a constant for time or something, it's very difficult to define. And consciousness for human beings is the same way. But quantum physics is changing how we look at consciousness. I would just say I would be very intrigued to look at the magnetic sensors that are looking at consciousness. I'm sure there are people doing it.
Before even the consciousness we have a lot of quantum physics is coming to the forefront of the technology now. There's a quantum computers are coming in, and then
Yes.
you can do the protein folding. It is already started solving the problem
Yes.
of protein folding.
Yeah.
And there's so
Nobel
many
Prize
things.
for
Yeah.
that.
And then
Yes.
quantum physics now sensors, and the quantum side is we never thought 20 years ago when I started in nuclear physics, nobody thought that quantum physics is anything to do with the medicine. At the time they never thought even computers are anything to do with the medicine. Now
Right.
we are going, we are getting in the new world, in the new kind of things. You are now you start a company with the quantifying the pain system. Quantifying pain is a very challenging, because the reason is, how do you subjective. The sometimes you prescribe there's medicines that scheduled drugs. So how do you justify that? One of them is quantifying pain is good. You could justify that. So that is
Yes.
a good things here coming up. A little bit, tell us your journey into the technology.
Yes. Well, Neurosensa, the reason I got involved was I was amazed that it's been the holy grail for us to be able to measure pain, right? We've never had, quote unquote, a pain meter. We've always asked patients, what's their level of pain, 0 to 10? Obviously, very subjective. And now Neurosensa has technology that measures electrical dermal skin nerve activity. But the key is you have to calibrate it, Ramana, against many, many, many patients, right? Because there's different numbers of glands, sweat glands. There is anxiety. There is the fact that they're sweating. And so those eccrine glands can change. And you've got to normalize these values over many millions of patients, right? And so that's why this is so amazing. We needed AI to help us with machine learning to dial in the accuracy on that and take the noise out. And that's what Neurosensa has done. So we've got some exciting pilots. I can't say with who, but they're major corporations in America. One in particular you would know, but they're going to be using it in their occupational division because people get injured at work. And this is going to help us measure pain and show that they're getting better. So that's one of many things to come from Neurosensa. I think it's going to change healthcare.
I wanted to ask you the question is there's a double-edged sword on this pain system. People
Yes.
get used it for pain medications, and now in the United States there are a lot of people are addicted to pain.
Yes.
You can classify them. It is addiction versus real pain they're feeling, right?
Yes.
That you can classify that process in that sense, right?
So what we'll be doing, Ramana, is working with pain clinics so that we can really justify. I'm not doubting anyone. Don't get me wrong. I'm not doubting people are in pain, but we're going to allow doctors to feel more comfortable, in fact, to giving pain medicine. Right now, if you go to a doctor and you had surgery, good luck trying to get even, 3 pain pills. They won't give it anymore. So there's a lot of scrutiny about pain, and there should be, because we had an opiate crisis. Even members of my family have died from opiate overdoses, and that may be related to fentanyl and having it mixed and all that. But the bottom line is that being able to measure pain objectively is going to be good in the end for pain clinics and for pain patients. When you really have it, you need it. When you don't, you don't. And we want to be able to separate those two groups in a very ethical and patient-centric way.
I'm going to ask you a hypothetical question before we close the podcast. If you are an advisor to the president, what kind of a strategy you give to the healthcare in the value-based care system, or the in the patient, in the technology-wise value-based care system? What kind of advice you give?
Well, that's a great question. You know, I was the head of healthcare policy for Chase Oliver. He was the independent libertarian candidate for president. And so my advice to the president right now is please do not cut Medicaid so deep that it hurts that safety net. I think we need to have a safety net for people that need healthcare. Number two, get a national-based value-based care system. We have a few pilots and we're trying some mandatory ones, but we need to roll value-based care out over the entire US. We played around with these pilots from the ACA long enough. It's time to get out of experimental mode, create a universal value-based care model where people are paid for quality and they're paid for lower cost and everyone wins. So I would say let's get involved in that. And here's the last thing. The patient needs to be on the healthcare team. They're not on these teams. They need to be brought into the value model where they benefit too. They understand why they're on the team and they have some skin in the game. And if we can align those three things, Ramana, we can really change healthcare in the United States.
You made an excellent point. They said they need to be part of the system, and then actually, you know, if the federal government worried about the cost system, they can actually save the money by doing a lot of prevention, a lot of remote patient monitoring.
Yes.
Take the care to the home. It can drastically reduce this cost. It's not a rocket science. It's not that much rocket science. That I think we need a good national policy on that. People like you would be absolutely wonderful addition to that kind of a thinking. Thank you, Dr. Deruelle. You know, you're absolutely knowledge. You know, I'm honored to have you on my podcast. Is a privilege, and you really shed a light on the entire healthcare system. And we need more people like you. You know, we need a ground changing thinkers, policymakers, and then revolutionary ideas that you bring to the table. We need people like you. You know, thank you so much for joining with us, Dr.
It's my pleasure, Ramana. Thank you so much. It's been an honor.
Yeah. Good night, all of you guys. Good night.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it.